I'm Dr. Troy Spurl, and our podcast is Synapse Snips. Our podcast teaches people about how the body is supposed to work, basically how we were innately made. Have you ever wondered why you get headaches? Ever wondered why you wake up and your feet don't work in the morning and they're achy, and then as you get walking, it gets better? Have you ever wondered why you don't remember your dreams? Have you ever wondered why you're gaining weight even though you're eating right, you're exercising, and the weight keeps coming on? Have you ever wondered why you're just feeling depressed? It's hard to get up off the couch. If you ever wondered about why you feel these things and why you're not just feeling right, listen to our podcast to get the answers. We get to the root cause and we tell you why. Make sure you're listening to Synapse Snips each and every week where we answer the questions that you guys have. Also, you can find us at officialsynapse.com. That's official Synapse, SYNAPSE.
Dr. Troy with Synapse Snips, and I am glad you're joining us today. We're going to be talking about PCOS, and we have our two stars here to address that, Dr. Ellie and Richelle, who are going to introduce themselves and talk quite a bit on PCOS. So let's start with you, Dr. Ellie. Let's just dive in, give everyone a little bit of an idea of who you are and what you do at Synapse, and then we'll go to Richelle.
Hi, I am Dr. Ellie. I have my degree in chiropractic as well as my master's in nutrition. And at Synapse, I am the pelvic floor chiropractor, and then I'm also the hormonal and PCOS nutritionist. So this is kind of my area of expertise. I'm very passionate, especially about PCOS, so I'm excited for this podcast today.
Awesome. And Richelle?
Yes. Hi, everyone. You might know me if I've been with Synapse for about a year now. I am doing the bioidentical hormone replacement therapy vein and arm of Synapse's entire crew. So Ellie and I go hand in hand when it comes to PCOS, and I'm super excited about the programs that she's bringing that's going to be available to women, whether you're menstruating, kind of in that perimenopausal transition, or a little bit beyond, because PCOS can affect you down the road, even if you are not technically still having menstruation. So we're excited to get into the nitty-gritty of that all today.
Yeah, I'm excited to learn here too, because you two are pretty elite at this area and with what you guys do. So I'm pretty excited here because I know I'm going to learn some stuff. just ask some questions. So there's a lot of women who have the diagnosis of PCOS already, and there's a lot that have symptoms who are struggling and they don't know. So let's just start with, and I want the people listening here, if you know of someone who's struggling and this sounds like them, send them this podcast because I know they're going to get a lot of value from it. So let's start with, what is PCOS? Who wants to start?
Ellie.
So PCOS overall is Polycystic Ovary Syndrome. So that it's kind of ironic though, because you don't necessarily need cysts in your ovaries to have it, but overall it kind of impacts a lot of different areas in a woman. It impacts a bunch of their different organs. For example, ovaries, it impacts their intestines. Women who have PCOS have a higher dysregulation of the bad bacteria in their gut. It impacts their hormone levels. So typically they often have higher testosterone. Again, not everyone has that, but some symptoms of that are kind of hair around the chin, hair loss. Often women kind of describe that they have anger. They also often have insulin resistance, which can kind of cause a bunch of kind of downhill negative factors going on into play. And then it can completely override their mood. Women say that they have a hard time controlling their emotions. Their menstrual cycle is not regular, so it could be every other month. They could not get them for 6 months. I had a patient who didn't have one for 6 months, and she had to go on progesterone, which Richelle will talk about, and that was able to bring her period back, but they can go months without having periods. So that's kind of like a general gist of PCOS. Richelle, what do you have to add?
Sorry, I'll let you chime in there too, Richelle. But what I'm hearing is it doesn't necessarily mean that there's cysts on the ovaries. So the name, it's much broader than the name, is what I just heard there.
It is, yeah. So it's kind of confusing, and it makes it harder to diagnose because of all of the different factorial things. And it makes it harder to treat as well, because often the regular medicine just treats the ovaries, but there's so much going into play that someone needs to be taken as a whole person.
I think what Ellie hit on the head, so PCOS, it's a little bit of a misnomer because it sounds like, oh, you have to have cysts on the ovaries to qualify for this diagnosis. That's not true. Like she said, it's usually a metabolic dysfunction baseline that often has to deal with insulin resistance. It can deal also with thyroid being subsufficient or under optimized. It can also deal with your vitamin D being incorrect. There's multiple factors that go into play. In the traditional medical world, we have something called the Rotterdam criteria. And you have to have 2 of the 3 to qualify for a PCOS diagnosis. And what those 3 categories are, Ellie alluded to. One is you have to have ovulatory dysfunction. So usually you have amenorrhea or irregular cycles, so inconsistent ovulation. 2, you have to have hyperandrogenism, which means, like Ellie said, acne that's very stubborn and flamboyant, hair growth in inappropriate places like those chin whiskers, or just you keep shaving it off and it comes right back. That's not fair. Come on, ladies, we don't like that, right? And hyperandrogenism can deal also with mood swings because the root cause of that is the testosterone sensitivity. And then you can have polycystic ovaries. That can be a criterion, which usually means that you have somewhere about 12 cysts or more, or you have an ovary volume that's higher than normal when you look on an ultrasound. But that is not the hallmark of PCOS. It is a symptom of PCOS. And so for people, when they're thinking about these things, do I have PCOS? Ellie hit nail on the head. There's a lot of different symptoms that go into this cluster of a syndrome. But again, you don't have to have cysts on the ovaries. In fact, you probably have a fatty liver before you have cysts on the ovaries, which is interesting to note. So you can be very metabolically dysregulated, not know it, and you can be very skinny. You do not have to be fat and have, I don't mean to be rude, but people often associate PCOS with a body type, and that's not true either. So it's a very interesting hormonal state to be a part of, and there's a lot of things that we need to do to treat the root causes.
You just danced around my next question there, so we're going to zero in on that too.
Sorry,
because
spoiler alert.
No, that was good. It was good. It's a nice little intro.
Mm-hmm.
In functional medicine, we like to get ahead of it. So even before it gets to the stage where we recognize it as PCOS, there's always like a development into that scenario. So can you just speak to some of the early signs, like you just said, with the fatty liver, but what are some of the early signs that both of you see with someone who has PCOS or is about to get PCOS?
Can I talk about labs, Ellie, and then you go into
Go for it.
So from a lab standpoint, there's something called your LH and your FSH, which are pituitary gland hormones that send signals down to your ovaries, your adrenal glands, and other organ tissues to make hormones. In a normal female who does not have PCOS, you will see something called your FSH to LH ratio be 2 to 1. Your FSH will be twice as much as your LH. FSH is what drives your estradiol production. LH is what drives your testosterone production. In PCOS, it is very classic. It's almost pathogenomic, meaning we can almost diagnose it consistently. You have that ratio flipped. So you'll have an LH twice as great as your FSH. And what happens with that LH being twice as great is you therefore make more testosterone. And you make more total testosterone. But what happens in a PCOS person, because that insulin is not well regulated, it suppresses your liver's production of what's called sex hormone binding globulin, which is a carrier protein for all of your hormones. So when you don't have that vehicle that's carrying around your hormones, your testosterone, which should be bound up to that carrier vehicle, is actually unbound and is called free. It's called your free testosterone. And that free testosterone that's running around in your circulation will be higher than normal on your blood slip. And what that causes is the sensitivity at the hair follicle. And so you get the acne, you'll get the hair growth, etc. So those things we can see very easily on a blood work slip. And Ellie might talk about that a little bit more with her urine testing and Dutch testing that she does. But on the blood work, I can see that. I can also see on your cholesterol panel, triglycerides are usually high, your HDL is usually low, your vitamin D might be low, your T3 level, actually your free T3, which is a marker of your thyroid performance. It's the hormone from your thyroid that does all the functions for you. That can also be very low because again, that when your sex hormone binding globulin is low, you don't produce T3 well in your body as much as you used to before. So those are some of the things just from an initial snapshot we can look at. Also, your estradiol will be high. Your progesterone will more than likely be low. Not everybody, but that will also be a function of this PCOS-like state.
Yeah, us guys really like that free testosterone thing, but I know the women, not that much. No.
We love it for our libido and our skeletal tissue, muscle mass retention. All those are good. But on the toxicity end, on the excistativity end, is that a word? It produces some really not so fun symptoms for us. And that's actually where those mood swings and the aggression, the impatience can come from. It's from that free testosterone. And so a lot of the therapies that are pharmacological, and we won't get into it now, but they target trying to raise that sex hormone binding globulin protein carrier so that we can move that free testosterone back into something that's bound, and so it won't cause as many problems. So Ellie, I'll let you speak.
That was so insightful. You're so smart. I love all of that information. I'm just, wow. So Richelle kind of talked about like the inside the body, kind of what you can experience, kind of a little bit more externally, is that what I find is that patients, when they're teenagers, don't really have regular periods. They have extremely painful periods. These are the girls that are missing school because their periods are so bad, or they either have an early onset or a delayed onset of their period as well. So you can kind of start to see the symptoms start happening even in their teenage years. It doesn't start to get typically bad. Well, we're starting to see it get worse at lower and lower ages, but in the mid-20s to mid-30s, that's when we really start to see the symptoms really amplify, when women are starting to want to get pregnant and they can't. Then they go to the doctors and they're like, I can't get pregnant. What's going on? They do ultrasound, they see cysts, they do blood work, they see the testosterone, and that's when you kind of get diagnosed. So a lot of the things that you can notice beforehand, before you want to get pregnant, and then it's like, oh, I have to work on this now, and trying to take care of your body before, is just recognizing, really look at your menstrual cycle. Your menstrual cycle is such a visible cue on your health of your body. So if it's not regular, if it's extremely painful, if you bleed a lot, women with PCOS say that they often wake up in a pool of blood just because their period started and they had no idea, or they're on vacations and then all of a sudden they don't have things because it's so irregular. That's not normal. You should be able to track your cycle. Your pain shouldn't be overwhelming. You should be able to keep on going on with your day. And then also the PMS symptoms with that acne gets really bad, but also that emotional brunt that a week and the week before and kind of during the period typically gets better during the period. So those are some of those like, oh, I should get this checked out.
And to touch on Ellie's point, some part of what's happening is when you don't have consistent ovulation, when you don't release that mature egg, you won't then go through your normal luteal cycle where you'll produce progesterone, because it takes an egg that has either been fertilized or not fertilized to be released and then travel through the fallopian tubes, put into the uterine cavity, for your body to signal that progesterone buildup. So if you're missing that progesterone second half of your phase, you're going to have symptoms related to that. And then you're going to have unmitigated estradiol buildup, and estradiol will continue to grow the uterine cavity and you won't routinely shed it. So when you do have a period, an inconsistent period with PCOS, you might bleed more because you have more tissue lining that has been building up over time. And so you're often progesterone deficient, and then it kind of stinks on the round two when you actually get your cycle, because now we have more buildup that we have to actually deal with and slough off. And we should talk about pregnancy at some point, but it's an interesting thing that you need to know. If you are PCOS and you are looking to get pregnant, there are ways to optimize your fertility, but then there are also things that we need to do to support you, because oftentimes your ovaries don't produce enough progesterone, and your ovary is responsible for producing the progesterone in the first part of your first trimester. In your first trimester, your second trimester, the placenta takes over, but that first greatest risk of miscarriage for PCOS women will be in the first trimester, because you're not producing enough progesterone routinely.
Yeah, and with functional medicine, we like to be proactive. So the earlier you can recognize potential dysfunction, the better. And we're seeing more and more and more of this. And we'll get to the reason why later when we get to some of the root causes. But with my chiropractic neurology background, one of the things I always look at is brain function. So let's talk about that a little bit, because there's an emotional component to this, because our hormones are regulated by our limbic system. Our limbic system regulates our autonomic nervous system, our hormones, and our emotions. So they are intricately tied together. So let's talk and speak to a little bit, not just the early signs of emotions, but the emotional toll of PCOS, because of the challenges that women go through. Because a lot of times they do everything right. They do what they've been told to do, and they're seeing nothing, no results, no gains from that. And that can affect you emotionally, which can actually then recycle back and cause problems with regulating your insulin, regulating your progesterone, and your ovarian function. So Ellie, why don't you start a little bit with just talking about the emotional toll of PCOS?
Yeah, first emotion that I hear women talk about is shame, because PCOS has such this negative connotation of that you're fat and you're lazy, and that's why you have PCOS. So we'll go into more detail on why that isn't even the case, but that is so front and center that women even have a hard time accepting the fact that if I accept the fact that I have PCOS, then I'm accepting that I'm fat and lazy, and that's not correlated to each other at all. So that is kind of like the first emotional component. But then what the disease causes itself, as I alluded to a little bit before, but it can cause so much anger. And I know that a lot of our listeners are religious, and so when you try to control your anger and you give it up to God, but you can't, that can kind of cause some spiritual dishevelment as well. And so when we work with you, we really do take all of that into consideration, because once you can start controlling your testosterone, that helps control your anger, and then that can help you trust God a little bit more and build that relationship even stronger.
Yeah, I want people to hear identity that we call a false identity. That is not your God-given identity. It's a false identity. So know that you have a different identity, and when you can surrender, that is actually part of the healing part of this. So there's flesh, which is what we're talking about here mostly, and the spiritual component. So the flesh component can really just derail you from a walk with God because of just how you feel. And so it's important to still address that. Faith and feelings are two different things. That's a different podcast for a different time. So let's speak a little bit more to just anything else emotionally, Richelle, that you have seen with your patients, some of the challenges. We've got anger, we've got some of the shame. Anything else that you've noticed with your patients?
Yeah, I think the PMS phase, if it does come on, that can be a very intense time, a very volatile, emotional time. Well, I'm so excited to work with Ellie is because she has programs that are going to help. I don't want to jump to the chase, but she has programs that are going to help with the consistency of patterns and habits and things to kind of support you emotionally through that journey in a way that makes it reasonable, that makes it understandable, that makes it not your fault. And so that kind of takes off some of the work that you've put on yourself in terms of being responsible, even, like this is all my fault. I did something wrong. And it brings a team alongside of you to help you through, which we need people. We need one another. I see on my end when I use bioidenticals, when Ellie gives me somebody who might be useful for supporting them with progesterone. Progesterone's a really great mood balancer. It helps women sleep if you take it in an oral capsule form at night. And so that deep rest will help restore, more than likely, Dr. You can speak to this, that limbic system and, the autonomic safety moving forward. And so I love using progesterone for women that really need it. Not everybody needs it who has PCOS, but for those that do, I do see them say to me as feedback of, I feel more like myself. Yep. And that's a joy to be a part of.
Yeah, some of the things I've heard is that when women are low in progesterone, they feel disconnected. There's mild depression, and their sleep gets disrupted. Absolutely. So those are early signs as well. So mild depression, feeling disconnected, and when you can feel more like yourself, just that can help with the starting process. And what I kind of heard you both saying there is the emotional part of it. There's a toll, but there's a plan, and Dr. Ellie comes with a plan. When it comes to undoing the slow process of how this got started. So this happens slowly over years, and we'll get into the root cause later. But when you can undo some of the things slowly and have a process, that's helpful as you're working on the biochemistry as well, as you're working on some of the root causes. So yeah, that's why this blend of Richelle and Ellie are so, in my world, it's just like, this is like the best Christmas present I ever got.
Well, we just sometimes don't know where to start, and that can be the hardest place to be in, because where do I go? Who do I talk to? Am I alone in this?
Right.
So giving you the tools to be able to register what you need is a first step, and then build on that. And coming alongside you in a team form, I think is just such a joy to be a part of from our end, and then such a gift to you that I think you all will enjoy, should this be you.
So we're going to talk about why this is actually on the rise as far as the just pure volume of women that are being diagnosed with this. So let's talk about some of the reasons, root cause reasons of why do women get PCOS? Why does this happen? Let's start with you, Ellie.
Yeah. So it's kind of crazy. estimated that about 10% of the American population of women actually have PCOS, and a lot of them aren't even diagnosed. And so there's this huge momentum to help women with PCOS because it is such a rise. So kind of some of the common symptoms no one really knows exactly why it's on the rise, but these are some theories. And so one of the main ones is that the environmental in our environment, there's just so much phytoestrogens out there that can cause havoc on our entire system. So the unclean drinking water, a bunch of plastic, microplastics everywhere can kind of cause chaos on our body. That's a contributing factor. Also stress, stress from even when you're a baby and a fetus, that can kind of cause long-term stress. That high cortisol causes insulin resistance, and that can be a factor. Also long-term systemic inflammation that can be caused by either your diet or a contributing factor of that stress. Multiple factors can go on to long systemic inflammation. And then there's a genetic component. So because we are able to actually diagnose it now, we're able to see that there is more of a genetic component. So those are typically, one person isn't just from one thing. It's normally kind of this hodgepodge of multiple different factors that we all kind of take into play to make sure that we're actually getting to that source.
Anything to add to that, Richelle? Because that was really good.
Beautifully spoken. I think maybe the value of having a team approach is that sometimes there are outlier things like adrenal hyperplasia, which can influence your testosterone to look like a PCOS picture. So sometimes we need to test to make sure that if you're someone who comes in with a high DHEA level, which can be normal for PCOS, we also need to rule out that you don't have like a benign growth or cyst on your adrenal gland. Dr. Troy, you and I've had a patient who had a pituitary cyst. So sometimes we'll see that LH and that FSH, and that's our first clue, but we don't actually realize there's other things coming into play that are influencing the downstream hormones from the pituitary level. So the fun part about being a part of an integrated team approach is that you'll get Ellie, who knows all these root causes. You'll get myself, who's kind of the insurance package and just surveys for other damage that could be done. That might be more of a zebra than the traditional horse that clops around. And then you'll get Dr. Troy, who will explain it all to you and make sure that you got it under your control. So, that's just the only thing I would say is that sometimes there are outliers to PCOS-like condition. It can look like you have PCOS, but you actually have other pathology going on.
Yeah, so I just want to go ahead, Ellie, and then I want to just go over that again because this is such a gem. This is what I want a lot of women to hear. One
more cause that I forgot about is actually post-birth control PCOS. So it's actually not true PCOS, but we are finding that girls who are put on birth control in their teenage years, early 20s, on it for 20 years or 10 years, they want to get off of it to get pregnant. Then they have this huge rebound of hormones that can cause symptoms that look exactly like PCOS, but actually aren't caused by it. So we can also help with that. I do have like a post-birth control whole protocol that can help women gently get off. And Richelle and I can, you don't do birth control though, but we all work together to make sure that you get off birth control healthy, because there should be a plan when you get off birth control if you've been on it for more than 5 to 10 years, because it does do a lot to your body.
Yeah, and I don't know of programs out there that give a birth control titration off plan or a roadmap off plan. I mean, I haven't heard, you could be the first one I've heard that from, Ellie. So, I mean, I know we're working together on it, but, doctors' offices around town, they just don't offer that. They just say, okay, go off it and, good luck. Hope you get pregnant. And what people don't, I think, maybe know is that birth control pills are a synthetic form of estrogen and progestin, and where they are actually working is at the level of your pituitary gland. Bioidentical hormones like estradiol and progesterone do not influence the pituitary gland in the same way that synthetics do. Synthetics go to the pituitary gland and they actually suppress the signaling of the pituitary gland so that you don't have these large surges of FSH and LH. And then when you don't have these large surges, you don't ovulate routinely. That's part of the mechanism of birth control, is that you don't consistently produce these eggs, so you don't have a chance of getting fertile. So it's interesting. So when your brain's been used to that silencing and that steadiness, it takes some time to relearn it, and sometimes it doesn't wake back up. And so sometimes we have to use modalities to try and zhuzh it back to life, or sometimes we just unfortunately see that the signaling becomes mismanaged continually still.
Yeah, it's important for a lot of people to know that hormones are a communication system. So they're more than that, but they are a communication system within the body and the brain. And so when you just break off communication, and say, now do the same function, but we're not going to tell you what to do anymore.
Mhm.
We're not going to give you the information. That's like going to your job and all of a sudden your boss says you can't talk to anyone, you've got to use sign language, but you don't necessarily know how to use sign language, or you learned it 10, 15 years ago. So it's a new communication system. So thank you, Dr. Ellie, for actually hitting on that one in particular. So just to sum up what we just heard there, because some of the root causes, these are speculative because there's not just one. This is my personal Dr. Troy Synapse opinion. It is a multi-system scenario, but environmental chemicals preferentially affect women more than men because of the pure volume of chemicals that mimic estrogen, the hormones in general. Women get affected by the environmental toxins, and we have peaked. And I lectured years ago at Duke University, and at that time they were well over 84,000 chemicals in the national database that the FDA had not actually been able to check to see what is it doing to us. Mm-hmm. Now, I'm going to make a prediction here. In the next 5 to 10 years, we'll have peaked when it comes to those chemicals because of changes that are being made right now, and then we should start going down. And hopefully we start to get a better sense of what they're actually doing to us. Right. You also said one of the biggest things, cortisol and then stress. We are seeing more and more people in general get into a fight or flight state. It's one of the biggest things we actually check for and look for here at Synapse, because when you're in fight or flight, you cannot be in rest and digest. So you start to see sleep and digestive disturbances because of that. So just the insulin resistance from the cortisol and the impact it has on the thyroid, recognizing that you're in fight or flight is one of the first things you can do to actually start to curb this from coming into your reality. So that was a big one. And then just the inflammatory stuff. You hit on 3 things: environmental toxins, fight or flight stress, and inflammatory chronic inflammation. These are things that we see en masse right now. So that's why I believe we're seeing an increased number of pure volume just for those 3 factors. So let's just not throw out all these the bits of information and say this is what it is. Let's talk about answering this question: can women get help with PCOS?
Ellie, I'll let you start.
They can, and it's actually really exciting, just knowing the ways that you can. So with my program and how I like to work with Richelle, and we kind of integrate with each other, is that we focus on 4 main components: regulating the organs, optimizing your hormones, overcoming sugar imbalance, and then thriving. So overcoming your organs, you have to work on your intestines and your liver, everyone, just so that they can actually heal. If you don't address those, then nothing actually ever stays, just because those are the foundations of making sure that your hormones stay in place, your insulin stays in place, and that you are absorbing and digesting food properly. So a lot of programs that I do see out there only focus on the hormone component of PCOS, and they don't even address that. And that doesn't create long-term sustainable remission of PCOS. Then we focus on your hormones. We deep dive into what hormones are dysfunctional in you. Like we talked about before, testosterone is typically high, progesterone is typically low, but that's not the case for everyone. So between Richelle and I, we either do urine test on hormones or blood test on hormones, and we find which hormone are dysfunctional on you. We use supplements and or bring in bioidentical hormones to make sure that everything is nice and balanced. Then we work on your insulin levels. If you don't work on your insulin levels, then again, that you won't ever heal, because sugar regulation is so important for decreasing inflammation, not getting type 2 diabetes, also are the cardiovascular risk, the brain diseases that are associated with it. Insulin resistance has a huge component of prevention down the line as well. And then thriving, as we talked about hugely, is that PCOS has a huge emotional component with it. We need to make sure that you are feeling supported, but also heard, understood. Often with PCOS, women are dismissed, saying that that's just a normal part of being a woman, or come back when you want to get pregnant, and they feel very devalued and not necessarily human because of just how people respond to them. And then that's shame component. So we work through all of that to make sure that you feel in control, you know what to do, and then you get to see really cool results. One of my patients I alluded to before, she didn't get her period for 6 months. And then within just working with me for 1 month, we were able to get her period back. Now she's 9 months post-program. Everything is still in remission. She's going strong. She knows exactly how to take care of her body, and she feels confident again.
That's key. Yeah. So what I love about this, and this is the big thing about functional medicine, is the education that's involved. And it's a little different than the traditional medical model, because in the traditional medical model, there's very little education beyond like prepping for a surgical component or whatever it is. So what I love is that you're equipping them both with the hormones, with the nutrition, and the knowledge of what to do moving forward. And I love the fact that there's a lot of attention. In fact, the heaviest lift a lot of times is around the insulin resistance and the lifestyle part of what's going on. So kind of hear that you have skin in the game when it comes to actually making these changes, but it actually puts more control back into your inner space when you understand it and you know what to do. And some of the frustrations that come with the challenges aren't not quite as overwhelming. And so I love the equipping that you guys are doing, because that's how you get long-term results. Equip them with knowledge, equip them with answers for the biggest challenges and problems. Can you speak to some of your success, Richelle, and some of your, just what you've seen as far as hope and just empowering people, women to
yeah. So where it comes from Ellie to I is that I have the prescriptive power for some other drugs. If you're a difficult case, and I don't mean difficult in the sense that you are difficult, I just mean in the way that your body does not respond as we would hope, maybe off the bat. So a lot of what Ellie's doing, and what I love is her focus on the liver, because again, this is an insulin sensitivity issue, and that's the liver will malfunction or not function as well in producing that carrier protein, that sex hormone binding globulin, if your insulin is consistently high. And so that sex hormone binding globulin carrier protein is just so important for people who have PCOS, because we want to raise it up so that we can get your testosterone rebalanced, so we can get your estradiol proportional, and so that we eliminate a lot of the clinical symptoms that you will have right off the bat, and then long term you'll have benefits down the road. So things that I can bring to the table, which are a little bit old school, but we use them in maybe gentler ways is the better way to say that than your traditional medical model. You probably heard of them before. We can use metformin to kind of help improve the insulin sensitivity of the pancreas. We can use spironolactone to help improve the sensitivity at the hair follicle. And spironolactone actually will help lower that LH for you, and will also help raise your sex hormone binding globulin. We use vitamin D. We'll use progesterone, usually in women who are inconsistent in their ovulation mostly. That's where I would use that for them, or who are looking to become pregnant, or who are currently pregnant right away. We'll use progesterone in those cases. We use desiccated thyroid to optimize your metabolism, and then to help again raise that sex hormone binding globulin if we can get your T3 level up. So those things are tools that I use in complement to Ellie's work if your body is just not kind of able to get the leg up that it needs, but usually it is with her. So I think some success story we've had is we have a PCOS patient who we put on progesterone. That's one that Dr. Troy, you and I worked together. And we had a difficult time getting her progesterone to actually stay steady in the first beginning. But we got it. We got the right delivery form, because delivery forms when it comes to bioidentical hormones are very important. Some women need vaginal suppositories. Some women need what we call like ready dissolvable tablets that go underneath your tongue. And so once we found that for her, she was able to sustain the pregnancy. And so that's the greatest success I could imagine, is the gift of life.
Yeah. I love celebrating those. I can't get pregnant, and then they're on child 3 now. So I love that. I am going to speak very, very briefly, 30 seconds for the guys here,
Sure.
because the exact same scenario, everything that sets up the PCOS in women sets up a metabolic syndrome with guys. Non-alcoholic, fatty liver, cortisol belly, and they have the same stuff going on, but it just shows up differently. So there's a lot of similarities when it comes to the guys. It just manifests differently as metabolic syndrome, and we see some of the challenges with the guys. They get shut down even emotionally as well. And I'm going to share one outlier, because this one, when we talk about stress, we're talking about mental, chemical, and physical stress as potential triggers. This PCOS patient of mine ended up being a root canal that got infected. And when we sent for the dental assessment, we found the root canal issue. Her original reason for coming in was not losing weight. We found an infection in the tooth that got corrected in the root canal, and then her metabolism turned back on. Like, we didn't really have to do anything because her cortisol levels started coming back into normal. Her insulin came in to normal. So the whole scenario was a hidden infection that ended up being the internal stressor for her trigger. This is why I don't believe you'll ever land on this is what causes PCOS. It's because it is inflammation of chronicity. It is stress, and it can come from infectious stress or mental stress and distress, and it is environmental toxins. So there's so many variables. So what we have seen, and I guess the important potential outliers, when you're not responding how we think you should respond, guess what that means? There's an outlier. And that's what Richelle was speaking to as far as leveraging the knowledge of the team. We have some brilliant people that will put in their 2 cents. And we've got a Dr. Josh who can just roll out the whole citric acid cycle at the top of his head, like he was literally just reading it. And whole Dr. Amber, who knows hormones, and Dr. Ashley, and Dr. Katie and Dr. Zach. So a lot of, and Tammy, our nurse practitioner, just a lot of knowledge there. So one last question, because I'm interested in this. I believe I've found women who had PCOS undiagnosed, who then went through menopause, and now because of menopause, their hormones are different, but they still have some aspects of PCOS. Is that even a thing? Is that something you guys could speak to?
Yes, absolutely. Because then if I get those patients and I'll put them on testosterone, acne pops up right away. Or hair growth more abnormal than just a postmenopausal response to testosterone. In those women, my first thought is, did you have a PCOS diagnosis that maybe went misdiagnosed? And so we check their cholesterol panel. We'll check maybe a liver ultrasound to see if they have a fatty liver. We'll check their fasting insulin to see if things are going on. Maybe they came in with a DHEA level that was a little bit higher, but your DHEA shuts down too as you age from your adrenal gland production factory, so you don't always catch it. But we can check some correlative markers again to see if possibly PCOS was in your history. You have a low thyroid, that might clue us in as well. But yes, it does happen. And with those women, we have to be a little bit more sensitive to the way that we're dosing bioidentical hormones, because they still have that underlying metabolic dysregulation that will influence the way their body processes the bioidenticals.
Awesome. Anything to add to that, Dr. Ellie?
No, I think she covered most of that.
Yeah, awesome. Well, great. Well, I want to thank you both for your time. I want to thank you for this valuable information, and to all the women out there who may be experiencing some aspect of this. I hope you find this just healing in the fact that knowing that there's an answer for you, and we have a team here ready to serve and be in service to you. So thank you for your time. I pray this finds the people who really need it, and they can be blessed and benefited from it. So thank you both.
Thank you.
Thank you.
Thank you for listening to the Synapse Snips podcast. If you like what you heard, subscribe to the podcast and share the podcast. To learn more, check out our website at www.officialsynapse.com. Until next time, this has been Synapse Snips podcast. We'll see you on the next episode. This podcast is for information purposes only and should under no circumstances be considered medical advice or a substitute for medical care. Any information given in this podcast is not intended to diagnose or treat any disease and is at the user's own risk. Please first consult a licensed healthcare professional.